A round of applause to Janosch Kratz, Spain, Germany, Brazil, Portugal, coming from Kalapa Clinic. Janosch? Oh, there he is. That's great.
Finally.
Welcome.
Better late than not arriving. I still need the... perfeito. Ok. Primeiro de tudo, obrigado pelo convite também por meu lado. Já imaginou, via o vídeo, mas imagino que já mostraram, então já sabem um bocado quem sou e que fiz. Falta uma pequena informação que fiz Erasmus em Coimbra e por isso posso estar hoje cá a falar com vocês em português. A apresentação vou fazer em inglês porque temos gente de todos os lados cá, então é melhor para todos. Então, obrigado por estar cá e muito obrigado pelo convite também à organização. I'm going to talk a little bit about the possibilities of treatment of cannabis treatment in pain. This is one of the first indications where we started to use cannabis, and a little bit controversial because there's a lot with the RCTs. Is it working? Is it not working? There's a lot of people, a lot of confusion around that theme. So I want to talk a little bit about that with you today. So this is about me. We already talked about it. I'm going to switch that and going to get, after the nice introduction in the endocannabinoid system of Christina this morning, we can start straight away. Just for repeating a little bit quick. When did we discover the endocannabinoid system? There was researcher Raphael Mechoulam, the godfather of all what we're doing today a little bit. He was trying to understand why we have a psychoactive effect when we use cannabis. So he was searching for that molecule which is the responsible for that effect. He found out in 1964 THC, delta-9 tetrahydrocannabinol, is the one responsible for the psychotropic effects of cannabis. So the research goes on, and we try to find out why this substance from the plant has this effect on us. And it took more or less 25 years later to find out there is a receptor in our brain and the central nervous system, especially, not just there, but especially there, which is the responsible. If THC gets attached to that receptor in certain parts of our brain, it's where the psychotropic effect comes from. So, why we have those receptors? That's the next question. Why our body has some receptors which react with some cannabinoids from the plant. So 2 years later, we find out, wow, our body produces cannabinoids by themselves. Anandamide, the first endocannabinoid known, discovered. Then it keeps going on. We are researching more. We're getting a little bit more interesting in the subject, and we find out, okay, there's another receptor, CB2, and then we see different other ones which are not specifically from the endocannabinoid system but related, and they can get modified by endocannabinoids and by phytocannabinoids, like the TRPV channels or, for example, the GPR55. There is research going on, and this list of cannabinoid receptors and cannabinoid-related receptors probably is going to grow and grow. There are more. There's GPR118 and several more which have some influence about what we are talking. So, a little bit brief. I'm going a little bit quicker through that so we're not delaying too much because we heard it already this morning. We have 3 types of cannabinoids. The endocannabinoids our own body produces, the phytocannabinoids from the plant, and the synthetic cannabinoids fabricated in the laboratory. So they all act through those receptors of the system, and like this we can modify those different functions the endocannabinoid system has. Mainly those ones. This is from the work from Vincenzo Di Marzo. We've heard that already in the morning. So these are the main functions of the system. And like Christina said, if all those things work well, eat, sleep, relax, protect, and forget, we're feeling kind of good. This is basic information, basic functions. If they're all correct, we're in a good mood and our body is working. A little bit more specific, you can see there are several of functions where the endocannabinoid system has influence about, or they modulate, from appetite, digestion, pain, reproductive system, cardiovascular, cell division, sleep, etc., etc. We all know the list is long, and it's going to be, we find out more and more parts or pathophysiological processes where we have an influence through the endocannabinoid system. But let's get a little bit more in detail in the subject of my presentation today, cannabis and pain. So, what do we know? Epidemiology of pain, of chronic pain. So chronic pain is a pretty severe condition, and especially nowadays we can almost say we have a public health problem with chronic pain. You can see we have an increasing prevalence. Every time more and more people are in the state of chronic pain. This is due to several causes. One is that we get older, and the second then that the medicine got better. We doctors do our work, and researchers do their work. So people in conditions where maybe a couple of years ago they wouldn't have continued their lives, now they can. But frequently, the result of that is they live longer, but they live with pain. So we can see in Europe at the moment 19% 19% of prevalence in chronic pain. It's more about 129 million people living with chronic pain in Europe right now. Most of the medical visits, almost or more than 50%, are due to pain as well. And this is not just a problem for the huge cost of the healthcare system and the companies because people cannot go to work. This is especially a problem for the patients because they have to live with that condition. They have to live with chronic pain day by day, and this can lead us even to increased risk of suicide. So this is a severe problem for the patients especially. What we have the situation right now is that the available treatment is kind of unsatisfactory. So what does that mean? That means that even we are trying to treat with all what we have, from gabapentin to opioids to NSAIDs or whatever, people are still with pain. So this is it's not working very good, our treatment with pain. And especially if in the side we have, besides that, we have side effects and toxicity, which frequently we have when we're talking about these medications, because it's not just one analgesic drug we're using, it's frequently several. We have to add some omeprazole to protect the stomach, etc., etc. And we get in kind of loop with a lot of drugs where we have toxicity not just for liver and kidneys, we have a lot of side effects as well, and all that affects life quality of the patient. We talked about it, opioid overuse. This is frequently said this is more a problem of the USA or of Canada, and in Europe it's not happening so much. I believe that we have a problem with that as well. It's maybe not as severe as we can see it in the US. This is a little bit related to the healthcare system there as well. But in Europe, we use a lot of opioids as well. And there's a lot of people suffering from that as well, without the satisfactory pain control. Keep that in mind. And the result is that we have a major issue in public health regarding that pain. Because if over 50% of the medical visits are due to pain, and a lot of patients receive unsatisfactory treatment, we cannot say that this kind of our treatment now at the moment is working. This is right now not working. So what do we know about cannabis and pain? This is now preclinical studies. Preclinical means that we are using human cells in the laboratory or laboratory animals. So this we have preclinical and clinical studies with humans, preclinical before, just for those who understand. So what we know in preclinical studies, what have we seen? That there are several cannabinoid receptors related in the modulation of the pain pathways. The pain pathways is what we have seen in the presentation of Christina this morning as well. It goes if we cut our finger, it goes through the dorsal horn of the medulla, raises thalamus, and getting to the cortex. And that way, we have several moments and several parts where several cannabinoid receptors have some influence about the modification of that information that gets up to our brain. In the central nerve system, the CB1 receptor is affecting the reduction of the central stress response. You can imagine that if our brain gets permanently information about pain, probably it's going to create some stress response. It's not a nice, healthy feeling we are arriving. So the reduction of this central stress response is very important in the chronification and the process of chronification of pain, which is one of the major problems. And it has an antihyperalgetic effect. This is a hypersensitivity to a stimuli which normally would not cause us pain in this in this terms, it does. An example is, for example, in fibromyalgia, where a little touch of the skin can create already a severe pain feeling. So it helps us to reduce that as well. CB2, it's interesting. It's the other cannabinoid receptor. And it's interesting that there's an increase of quantity when we have a tissue lesion or inflammation. So our body creates those receptors in the places where there's the problem to solve the problems, to have like this anti-inflammatory effect. And we can see, or we saw, that CB2 is implicated in turning a pro-inflammatory environment into an anti-inflammatory environment. So it helps us to reduce inflammation in several parts of our body. Another thing which I think it's pretty interesting is that the different receptors of the system are co-localized. So they're pretty close to each other and they influence each other. So this is especially in the peripheral and central neurons. This is again in the parts of our body which are implicated in the control or the modulation of the pain perception. And last but not least, there are interactions between cannabinoid receptors and opioid receptors, which opioid receptors, of course, are one of the most important parts for the pain treatment. So it's pretty interesting to see that they both there's a relation between both of them. So let's keep the preclinical. Let's get to the clinical. This is maybe a little bit more interesting. I selected two studies, just because there are several of ones, just to show a little bit what we know right now. So first of all, in acute pain, we have seen that cannabinoids might not help so much. We have not seen that we can reduce with cannabis acute pain, but in chronic pain, yes. For example, this is a high evidence study with 2,500 patients, and we can see with the successive meta-analysis, so this is a high quality study, and we can see effective in chronic pain. And another one, for example, in multiple sclerosis, we can see reduction of pain, reduction in spasticity. So we can see it goes more in the direction of the chronic pain where the cannabinoids can help us. This is just for now that you can see it's not just two I selected, there are several of them. This is out of the YAMA studies. This was used in Germany 2016 for the elaboration of the law, which started in March 17th of 2017 in Germany. So you can see there are several studies done, everyone with low or moderate evidence that it helps in chronic pain. So let's get what information gets taken out on this and what we can see reflected in the guidelines. Guidelines are the new thing between doctors. Doctors, 2019, everything is about guidelines. 20 years, 30 years ago, doctors had to think. Now doctors have guidelines. Yeah? This is a little bit sad because we are shown, as young professionals, we are shown always that the guideline is like the highest thing. We should have for everything a guideline, and if you're doing exactly what's written in the guideline, you are safe, you're doing everything right. The problem is nobody's looking at the patient anymore. We're looking at the guideline. And that's a major problem, especially as a GP. And in a lot of situations, this is a major problem because we are treating patients like numbers and not like they are there. So we cannot compare frequency situations. And having those guidelines, no misunderstanding, they're a huge help. Yeah, they tell you they don't have to read through thousands of articles and stuff, but we cannot take guidelines as the only evidence. We have to use them for the right thing, but we have to still look at the patient and see if the guideline it's matching with the patient or not. So, but besides that, let's check what the guidelines say. European guideline, European Pain Federation. Should be used as an adjunctive medication if the first and second line didn't work. All right. European Federation of Neurological Societies. Their second or third line. So we can use it already as a second line. Okay, getting better. Canadian Pain Society as a third line option. Okay, but just in neuropathic pain and in certain conditions. And the International Association for the Study of Pain gives a weak recommendation against it in neuropathic pain. So this is a bit confusing. So we have those guidelines, doctors look at those guidelines and they say like different things, what we're gonna do. It looks a little bit like this, no? Do you like me, don't you like me, maybe, I don't know. I'm just checking, I have to find out. confusing. No? So I want to get a little bit more profound in that place, and I want to explain why we have so many different results out of the same studies. We are talking about science. It should be easier. There should not be one science at one side of the Atlantic Ocean or the other side, or in France a different science than in Germany. I mean, how is that possible? It's a little bit possible because there are major problems if we look at those studies. There are studies which we are taking all types of different things and we are comparing apples with pears. Yeah? What are the main problems in those studies which we are comparing? We can see them at the left side. The products used, for example. We are comparing in all those studies which they were used for elaborating those guidelines. There are different products used. We are comparing oral preparations with vaporized cannabis. We are comparing different terpene profiles, or we have no information at all about the terpene profiles. There are studies which say, okay, the patient used 1 gram of cannabis per day during 30 days, and then they're checking before and after the pain. I mean, okay, that's good, but what kind of cannabis? We can already predict, depending what they're using, what's going to be the effect, for example, on the side of the side effects. If we use a strong indica strain or high in myrcene linalool, at the adverse events, they're going to be all sleeping the whole day. If we use high limonene or other terpenoids, they have more probability of having tachycardia or feeling anxious. So we have to define exactly what are we using to be able to predict as well what's coming out. Administration routes, the same thing. There are several studies comparing, like I said before, oral preparations with ingested, with vaporized extracts or whatever. We have to know exactly how it works. Do we have a first level degradation or not? Are we using, is the effect longer or shorter? This is all depending on the administration route we are using, and it depends, it's changing the outcome of the study. The same is about the dose used. There are a couple of studies where they said, okay, cannabis helps, cannabis does not help. How much? Again, it depends. We have to know 1 milliliter of cannabis extract, was Mara was saying before. 1 milliliter can be way too much, and 1 milliliter can be way too low. It depends what's in that milliliter. That's what you need to know, and a lot of studies, this is not exactly described. The same thing before. We need to know as well, if we talk about full plant extract or pure cannabinoids, full plant extract is just another big question mark. What is a full plant extract? I mean, we have more than 2 ingredients there. Okay, but which ones? That's what we need to know to be able to work with those studies. And the blinding, it's a stupid thing, but it's a problem. Blinding we need for those studies because we need to understand, we need to compare it to placebo. Now, if we don't have the smell, the taste, and not the psychotropic effect, people are going to find out pretty quick if they're getting the placebo or not. Because one group is going to have more fun than the other one, and they say, I want the right one as well. So this is a stupid thing, but we have to keep that in mind as well. The blinding can be a problem if it's not properly done. Another thing is the parameters used. In those studies about chronic pain, we frequently just look at analog scales, which talk about the intensity of pain. Pain gets from 8 points to 6 points. Okay, reduction of 2 points. Great. If we talk about chronic pain, there's way more to talk about. Sleeping, appetite, how's the person feel? Does she go out? Does she not go out? Does she stay at home? Are we going to get this grumpy person who sits on the sofa, has a bad mood, doesn't want to go out and is mad at everybody? Or we have a 6-point chronic pain, but we are able to talk to our nephew, go out, listen to some music, and we are some active. So there are big differences, and that's what is shown in those studies. That's why we have so many differences between of all those studies, and the outcomes are going to change as well. So we have to ask ourselves a couple of questions regarding this. Are we using the correct preparation for the different pathologies? We cannot expect, for us, for a lot of people, cannabis is still that gray herb. We go to that dark corner of the park, we buy some green herb, we put it with tobacco and some paper, we light it up and we get high. That's cannabis. If we talk about a medical treatment, that's not cannabis. We need to know, we cannot expect from one plant to treat 25,000 different medical conditions. We have to know exactly. For insomnia, The preparation is going to be different than for epilepsy. They're going to be different for multiple sclerosis, for anxiety disorder. This we cannot expect from one single thing to treat all of this. I mean, it's from the same group. It's already a nice thing that we can say, okay, we can treat with cannabis so many different conditions, but we need, again, to specify what is exactly what we are using for which condition. Another thing is the appropriate parameters. We already talked about it there. We have to establish more things. We have to look at more things than just the pain intensity. The RCTs, we have some problems with that regarding what we are saying before. And again, down here, we should not look at the pure reduction of pain intensity in those studies. We should look if people are able to go to work, if they're able to dress themselves, wash themselves, if they go out, life quality, sleeping, etc., etc. There are way more factors implicated if we talk about chronic pain than just the intensity of pain. So, what are those different properties cannabis is adding us when we talk about chronic pain? I mean, we have seen in the studies that it can reduce with a moderate or low prevalence that the pain intensity, but where does cannabis help us more when we talk about chronic pain? And one important thing is, again, what we were saying before, the reduction of the central stress response. Yeah? Most of the people, chronic pain causes stress to our body permanently. We are under stress, and the endocannabinoid system helps us to deal with the stress. So if we are able to modulate the system and to enhance it in the way we want, this can help us to reduce that central stress, which is a very important part of the chronification process of chronic pain. Cannabis helps us to delete some memory content, like we heard this morning as well. So this is an intrinsic part as well, because we have about 70% of people with chronic pain are fulfilling criteria for trauma. So we need to delete traumatic information. It's very important, and it's one of the bigger important functions of the endocannabinoid system, especially regarding chronic pain. We have psychosocial symptoms associated. If we have pain the whole day for years, our mood's not going to be great. Yeah, we're going to be anxious, we're going to be depressive, we don't want to go out, we're in a bad mood at home and don't want to see anybody. If we have a treatment which reduces pain and helps us with anxiety and depression, it's already a big step. Maybe we, instead of sitting there and saying, I want to jump out of the window, they say, well, the pain maybe it's 6 points anyway. I'm going to put some music on. I open the window. Maybe the nephew comes by and we go for a little round, and it's going to help to break out of that vicious circle, to be able to do more. So it's enhancing as well this social behavior if we are able to reduce the anxiety and depression, which is frequently associated to chronic pain. The relation to the opioid system, this is interesting. This is not just property of the endocannabinoid system, but if we're able to reduce the amount of opioids we're taking, we give people back life quality, in terms of especially the normally related side effects, nausea, vomit, cannot go to the bathroom, doesn't feel good, no appetite. So if we can help that, even if it's just without, for the reduction of the dose, it's already helping. And we have the improvement of other symptoms which are associated with chronic pain. Again, sleep, mood, anxiety, appetite, etc. So why we have all this? It's suspected that the endocannabinoid system is acting more through the limbic system than the sensory system. And that means that it doesn't affect so much the intensity of pain. What it affects is the perception of pain. So this is exactly what I meant before when I said, okay, it's maybe the same intensity of pain, but instead of wanting to jump out of the window, we are able to manage to live with that pain, and it doesn't impede us to do more things. And with this, we get out of that vicious loop of chronic pain, we get to some more healthier loop, and we can break out of this. And this is helping us a lot in terms of life quality. So, how can we fit, or how can we integrate cannabinoids into ongoing health system? This is a pretty interesting thing for Portugal, especially. I mean, I know the situation you are in right now here. I believe it's 11 or 12 indications where in Portugal you can prescribe medical cannabis. There's no products and there's nobody knowing how to do it. So this is a very interesting thing to do because the patients are waiting for it. The one suffering under that situations are the patients. So what should we do? We have to talk about that medical cannabis is neither magic nor myth. Yeah? That's a very important thing because it's frequently a misperception that either cannabis, you are giving people drugs, or people saying, wow, this helps for hair loss, for any kind of toenails or whatever. No. This cannabis is like a lot of other substances, has indications, has contraindications, has effects, has side effects. So we should use it like this. We don't need those extremes to be there. We should use it like any other drug as well. We can do it. Yeah? It doesn't help us to call it in a bad name or in a too positive name. I mean, we have to keep it like it is. We have to research and to find out and treat it like it is. So this is a very important point regarding that subject. The anti-stigmatization and the fear. There's still a lot of stigma around cannabis. Yeah? People have fear about it. I'm going to use it. Am I going to get addicted? What are the neighbors going to think? And this stigma and fear, it's not just for the patients. This is for the doctors as well. Nobody wants to be the weed doctor. What are going to think the other patients, the other doctors about me if I start to treat with cannabis? They're going to laugh at me. I'm going to be like the weird one. Unfortunately, the medical society, pretty much all around, it's a little conservative still, and you are frequently and quickly in that direction. Ooh, what is this guy doing? I can tell that by myself. I'm a pretty young doctor, and I started to be the weed doctor. And now I'm trying to find out a little bit, especially with the ring in the nose, it's not helping, so you're the weird guy, the colorful guy anyway. But we can see in Europe that this is getting step by step in the right direction. So I can just say to my colleagues, use it scientifically, use it in a good way, in a controlled way, but use it. Use it for your patients. We all had we all are talking about we are there, or we studied what we studied to help our patients. So now just because of fear, because of that, we cannot stop and say, well, no, but with this cannabinoids, I don't know. I'm going to get back to the opioids. Why? No difference. The only way to end stigmatization and fear, by the way, is education. Yeah? Education, it's very, very, very needed pretty much all over the world, especially in Europe and as well here in Portugal. Education not just for the doctors. For doctors, for pharmacists, for nurses. Unfortunately, from Infarmed, I think there's nobody here. It's a little sad, but I would love that there would be more people interested. There too? Okay, perfect. I'm sorry, my fault. Nice then, welcome. Nice that you're here. I'm happy to talk about. Excellent. I don't know where they are. Little fault. Okay, no, but education is very important as well for the patients than for the doctors, because there's so much weird information, so much fake news around it, so we need a solid information. So I really ask the responsible politics, the responsible people at the medical colleges to create educational programs for your doctors so people can start to use it in the right way, and they don't need to go through fancy websites where nobody knows where the information comes from. Another important part is the complete information on positive and negative things. We tend, like the people working with cannabis or in the sector, one side tends to be super negative and the other side tends to be super positive. We have to talk exactly in the same way about the positive effects like on the negative effects. And we have to start a treatment and we have to stop a treatment if it's not working. It's often perceived that cannabis treatment, we start one time and then people are smoking weed the rest of their lives. No. I mean, we have to start it, we have to stop it if it's not working. So it's just like any other medical drug we're using as well. And then now, what is this weird German guy now saying? Das Rad nicht neu erfinden. What is that going to mean? That means we don't have to rediscover the wheel. We already know it. Yeah? Why I'm saying this? Because in medicine, frequently, we have like conventional medicine and we have cannabinoid medicine. And it's kind of confusing because we are using already substances which are psychotropic. We are using already substances which interfere with the possibility of driving, for example. We use already substances which can be complicated for elderly because they can fall. We use substances which can be addictive. So this is not something new cannabis brought to medicine. This is pretty much medicine completely. Every substance has some of these parts. So why we're treating it like a different thing, or why we're paying so much attention here if we're using on a daily basis in every country of Europe or of the world, we are using substances which comply with those properties, and we have no problem with them. So this is very important that we don't put that in a different part. We just have to integrate it like other things as well. If we start an opioid treatment, people should not drive until they're stabilized and they know how it works. With cannabis, it's the same. It's like people, if we start a new treatment, they should not drive the next day. But they can drive if it's stabilized. In Germany, for example, after 6 weeks, people can get to the responsible, to the, how you say that, where you get your driving license and you get like a special stamp inside. If it's stabilized and the doctor says, okay, people can drive under the control. It's okay, if it's controlled. No any other thing like with opioids as well. So, to show that, a little statement from the US, which is exactly showing what I say there. Marijuana is not a completely benign substance. It's a powerful drug with a variety of effects. However, except for the harms associated with smoking, the adverse effects of marijuana use are within the range of effects tolerated for other medications. So what else? What else we need to say? It's the same thing like we have it in other medications as well, and it's important to treat it like this. So just to get briefly through it, we have seen cannabinoids are effective in reducing chronic pain. It helps better to tolerate pain. It's more about the toleration of the pain than about the intensity, but it's going on the same directions. We have reduction of stress, fear, trauma, and symptoms associated. We have other symptoms where it can help. We have the synergistic effect with opioids. They seem to not be effective in acute pain, and they're generally well tolerated, poorly toxic, and safe. So I want to end my presentation again regarding a little bit the situation in Portugal, and I want that the doctors have that in their mind, because a lot of people I can see, a lot of medical professionals, they hide behind the fact that I don't know exactly how it works. Not knowing is not protecting us for letting the patient being alone that way. So if we don't know as a doctor, we have to learn. That's why we are doctor. We do that in every other part as well. So with cannabis, it's the same thing. We cannot ignore that cannabis exists just because if you look in the past, there was some people smoking weed. If we don't like that, good, don't like that. But we're talking about the controlled medical treatment. So if we don't know, we have to learn because the patient can benefit from it. And because of that, one statement from one of the other godfathers of what we're doing here. Last year he was here. This afternoon you're going to see him through a video conference. Ethan Russo said in Beyond Cannabis, this statement, I think every doctor and as well the political representatives should keep that in mind if they're regulating and if we're on that process. Thank you a lot. Obrigado.
Thank you very much.
Oh, thank you. So we have 3 questions through the app. The first one, Rita Pereira, may I ask the... Okay, right over there. And then we have another one, Bernardo Pessoa. Okay, there. And we have Antonio Pacheco. Okay, right here. So we have questions in Portuguese and questions in English. And since you're an international, we're going to read some questions in Portuguese and some questions in English. So, Michael, would you please... We were practicing.
I need to practice my Portuguese, so don't laugh too hard at me, okay? Be very gentle. Okay. Cada paseo reage de manera diferente aos cannabis tem necessitos de dosagem diferentes. How's that? Oh, that must be really bad.
Great, Michael, you're amazing.
I promise I'll practice harder. Duolingo, I told me my first lesson.
Okay, so quickly.
Como perceber isso?
Did you get it?
How's that?
Okay, each person reacts in a different way to cannabinoids and has different dose needs. How can we understand that? You were great, okay, Michael?
I mean,
thank you. My self-esteem is really...
how are we going to do that? I mean, we're doing that already. Yeah, with opioids, it's the same. Nobody has the same dose. And with other substances, it's a little bit easier. but we saw the principles before. I mean, we have to start, the general rule is start low, go slow. So we start at a low dose and we start to increase it step by step until we have the effect. The only thing we need here, it's more contact with the patient. We need to talk to our patient. It's more work for us as a doctor, yes, but it's not a bad thing to see the patient maybe 1 or 2 times more. And this is as well not misunderstanding. We're talking about the titration period. So we're talking about maybe the first 4 to 6 weeks, which until we find the stabilized dose for our patient. It's not that we need to see our patient 3 times a week, years ongoing. No, this is at the beginning until to find it. And one time found it, people stay pretty much stable on their doses for a lot of time. It's not that in case of other drugs that we need to increase it permanently. One time found the dose, it keeps it. Maybe we have to increase it a little bit. Maybe the situation, the medical situation, symptom intensity changes a little bit. But generally, that's the same rule. And again, with opioids, we're doing the same. We start low, and we start increasing, and we see how are the side effects and how is the medical effect. And regarding or depending on the effect, we do it. So this is with cannabis, the same thing. It's a little bit, I mean, we have to learn how to do it. You have to learn how to titrate. You have to learn as well how to evaluate the patient. So it's important to do a well-done first visit with the patient, get through a couple of things, knowing, I, for example, ask frequently patients how they generally react to medication, how they generally react to alcohol, for example, to understand if how is their metabolism, to understand a little bit, are they sensitive to those substances or not, to estimate where I'm starting. But this is just for saving some time. If you want to be at the safe side, just start like Mara said. You can start with 1 milligram and you just increase every 2 days, but if you increase in the night, step by step, and you do it. Gaining more experience, you don't have to start so slow. You're going to learn a little bit how it works, and you can do it a little bit quicker. But this is it's not magic. You don't need to be a magician to work with cannabis. It's like a lot of other drugs as well. And another thing, I think maybe this is a nice thing. We should do it with other drugs as well, because I believe that a lot of medical drugs, we are overusing them. I mean, it's just easier to say, take ibuprofen 800. It would be better to start with 100, with 200, with 300, and to see, oh, maybe the patient responds with 400 milligrams already, and we don't need to get to 800. Because it's easier, we just give like more, and we say, okay, whatever. But I hope I answered the question.
Great. We have 2 more questions. Besides the needed education, as you mentioned, Doctor, what other things are delaying the generalization in use? And how much time do you predict that this could happen in Portugal?
Wow, that's...
Look into your crystal ball.
I'm going to see the ball. Let me see. Now, I think in Portugal we have 2 major problems. I mean, finally we have the legal frame, let's say, that we are able to prescribe cannabis. But the big problems we have, first, we have no products. And this is, I think, a big problem here. I don't know where there's the problem. If it's at the side of the companies or if it's the side of the political control, that it's now for almost a year that we have the law and there's still no available product in the pharmacy. This is not acceptable. This is not acceptable, especially for the patients. I mean, you know that it's existing, you have it there, you cannot get it. It's not possible. Okay. That's one part, and the other part is again the education. You can do anything if you have to, even if you would have the product and you don't have anybody to know how it works, it's the same thing. So what we need is a safe, controlled product, and we need educational programs from part of the dos médicos or from the pharmacists, from the nurses, from the doctors' college. We need educational courses that people lose the fear and are able to work with it.
Okay. Last question before lunch. Will the CBD act synergically with antidepressants in the management of chronic pain, or this combination is not adequately studied yet?
Again,
I'll say, okay. Will the CBD act synergically with antidepressants in the management of chronic pain, or this combination is not adequately studied yet?
I mean, there are no specific studies if there is a synergic effect in between of different antidepressants and the CBD use. What we can see at the other side, there are a lot of people using CBD and using antidepressants, and they're perfectly fine. there's no problem. We have to keep CBD. We have to keep one thing in mind. It's that the degradation is through cytochrome P450, which is an enzyme which degrades more or less about 60% of the medical drugs we're ingesting. I'm going to talk a little bit more in detail about that tomorrow in the conference. But so we have to keep that in mind. So maybe we need to adapt in dose. But with antidepressants, there is pretty much, it's an added anxiolytic effect, but there's neither toxicity nor synergistic effects known right now, at least as I know. So there's no complaint.
One more question from Miguel Roja, if you could. Miguel, thank you very much, sir. If chronic pain patient
No mic.
If a chronic pain patient
No
needs
mic.
cannabinoids for a long period of time, how can you monitor the patient's tolerance and not increase his dosage too much?
I was confused with which one is it?
Number one.
Okay. I mean, of course, if we use it for a long time, what we have seen in terms of tolerance. Sorry. Can you?
I'll repeat it, I apologize. If a chronic pain patient needs to take cannabinoids for a long period of time, how can you monitor the patient's tolerance and not increase his dosage too much?
I mean, to monitor the tolerance, you can see what you're giving him and how's the response. You can keep doing the analog pain scale and you can see, okay, how, if we want to keep the pain by, let's say, 4 points, how is the dose we need to keep it there? This would be one part of monitoring it. In general, about the tolerance, we have to say the tolerance to the psychotropic effects of THC is developed way quicker than the tolerance to the medical benefits. Why? We don't know. But we can see that in terms of that we need to adapt the dose time to time, but relatively in a low amount. So we don't need every couple of weeks to increase the dose. It can keep stable, but the pain conditions change. I mean, if we have, for example, an anti-inflammatory part as a reason for the, or as a cause for that pain, if the inflammation gets reduced, pain gets reduced as well. This does not mean that the cannabinoids regarding the pain help. If they are the responsibles for the anti-inflammatory effect, it's another thing again. But it's going more or less in that direction. I mean, the adaptation, we need to adapt with time to time. It's not in high adapting, so we don't need to increase incredibly the dose. And how to monitor it, it's doing the pain scale and comparing the pain the patient has and the amount of cannabinoids it's taking. We as Kalapa, for example, we use the standard pain scale, and we have done for ourselves adapted one to the cannabinoid use, and we use as well the SF36, for example, for life quality. We added as well to see the evolution of it, because we don't want to look just at the pain scale and other aspects as well. But there's no guidelines in terms of cannabinoid treatment right now, so everybody's doing a little bit what he thinks is the best, and ones are doing it better than the others. But I believe and I hope that in the future, as well in this sector, we're going to have a better exchange in between of professionals. We're going to have better educational programs, and we're going to have like more standardized way to work with all that and more answers to all that questions we still have. Thank you.
Okay. Thank you. Thank you, Janosch.